Bismillah ar-Rahman ar-Rahim. I am Ahmed Mahmoud Rajab, a lecturer of ophthalmology at Alexandria University Hospital. Today, I'm going to discuss an important topic, which is the sclera. Today, we are going to discuss the importance of sclera as eye structure. And by the end of this lecture, you should acquire knowledge about the diseases which affect the sclera, the common diseases which affect the sclera, and to know the association between the sclera and systemic diseases. In addition to this, you should know the importance of scleral diseases as a cause of red eye and apply this knowledge. So this is a hint regarding the anatomy of the sclera. So the sclera is the white part of the eye. This is the white part you see when you examine the patient's eye. And this sclera with the cornea form what's called the outer protective layer of the eye. So the outer protective layer of the eye is composed mainly of the cornea and the sclera. So the cornea forms the anterior 1/6 of this outer protective fibrous coat, and the sclera forms the posterior 5/6 of this coat. So again, sclera forms the posterior 5/6 of the protective layer of the eye. Sclera extend anteriorly to join the cornea at what's called limbus, and posteriorly it joins the meninges around the optic nerve. So this is the optic nerve, and there are meninges around. So the sclera joins this meninges posteriorly, and anteriorly it joins the cornea at the limbus. One of the major differences between the cornea and sclera is that the cornea is transparent because the regularly arranged collagen fibers. However, the collagen in sclera is haphazardly distributed. That's why sclera is opaque. Another important feature regarding the sclera is that it's covered with what's called episclera. Episclera is a thin connective tissue layer covering the sclera, and it's form part of a scleral structure. As mentioned before, the sclera should be white in color, and any change of the scleral color should alter your attention that there is something unusual going on. Most important thing regarding the sclera is when it changes its color to blue. So blue sclera is abnormal sclera, and it mainly happens with connective tissue disorder like Marfan syndrome and osteogenesis imperfecta. The pathology behind this, in this connective tissue disorder, is the thinning of the sclera with exposure of the underlying choroid color. Again, it may happen in cases of what's called staphyloma, in which there is weakening of the scleral tissue with exposure of the underlying choroidal structure and choroid colors. So what we are going to discuss today is the inflammation of sclera. Inflammation of sclera divides into two main categories. Inflammation of the outer layer of sclera, which is the episclera, we call it episcleritis, and inflammation of the actual tissue of the sclera, which we call it scleritis. And this division is of much importance, as we will see as we discuss this lecture and as we give hints about episcleritis and scleritis. So let's discuss episcleritis. Again, episcleritis is the inflammation of the outer layer of sclera, which is the episcleral tissue. It's much more common than scleritis, and it's benign and self-limiting, and it's usually unilateral. So it's very uncommon to see a bilateral cases of episcleritis. And both of these conditions, episcleritis and scleritis, are much more common in women. So episcleritis also has different types, either what's called the nodular form and simple form. Nodular form, from its name, where there is nodule, inflammatory nodule on the surface of the eye, where there is inflammatory signs like redness and edema formation. So there is inflamed nodule on the surface of the eye, and it's less common than the simple form. In simple form, there is no nodule, just inflammation on the surface of the sclera, on the episcleral tissue, which may take a sector, a part of the eye, or it may affect the whole scleral tissue. There is no nodules again. It's again much more common in females, and it's usually there is no recurrence. But if there is recurrent episodes of episcleritis, this should alter your attention that there may be underlying systemic inflammatory disease. And this is one of the important things that you should know about episcleritis, that in recurrent cases, you have to search for underlying systemic condition. So what are the causes of episcleritis? It's most commonly it's idiopathic. There is no underlying disease, no underlying cardiovascular or connective tissue disorder or any vasculitis. So the most common cause of episcleritis is the idiopathic form without underlying disease. But in case of recurrent condition, recurrent episcleritis, you have to search for what's called collagen vascular disorder, like rheumatoid arthritis, systemic lupus, and seronegative spondyloarthritis. In addition, you have to look for vasculitis or vasculitis, like polyarteritis nodosa, temporal arteritis, or Behçet, and inflammatory bowel disease like Crohn's, ulcerative colitis, or rosacea, gout, atopy, infection whatsoever. So episcleritis, when it takes place as a single solitary episode, so it's usually idiopathic and you don't have to search for underlying etiology. But if the patient has recurrent attacks of episcleritis, you have to search for underlying cause like this list. Clinical picture, again, the symptoms is mainly red eyes. Patient may come just complaining of red eye. So red eye is pain or discomfort. The pain is usually mild. It's not severe pain, so we call it discomfort. So red eye, which can be, again, acute in simple scleritis or subacute or gradual in nodular episcleritis. Again, pain is not prominent as scleritis. It's just the discomfort or mild pain. Some patients may complain of photophobia. So is there any clinical signs you are going to search for? Yes. So you will search for what's called episcleral vascular injection, which again can be sectoral or diffuse like here. So it's just vascular injection or inflamed nodule on the surface of the eye. Again, there may be chemosis, edema of the conjunctiva, and this, if there is nodule, it's usually tender to touch. But again, it's easily mobilized over the sclera because it's on the surface of the sclera. It's affecting the episcleral tissue. So you are able to mobilize this nodule with cotton tip applicator. Is there any pharmacologic test to differentiate between episcleritis and conjunctivitis? Because both of the condition can cause red eye. So there is pharmacologic test using phenylephrine 2.5%, 2.5% in the affected eye. If there is blanching of the affected vessel, so it's a conjunctivitis. But if the hyperemia persists, so it's episcleritis. So phenylephrine 2.5% is able to constrict the conjunctival blood vessels, but not the episcleral blood vessel. So this is a simple pharmacologic test to differentiate between both of them. So how to manage this case? Again, episcleritis is usually self-limiting, and if it's just solitary attack, so you don't have to search for the underlying cause, and you just have to give symptomatic treatment. So again, investigations, episcleritis usually clear on its own without any treatment. It's a benign condition. And systemic evaluation only necessary when there is recurrent attacks of episcleritis, and you have to exclude underlying systemic disease like connective tissue disorder or vasculitis. The treatment usually supportive. Again, in case there is pain or discomfort, you have to give supportive measure like cold compresses, iced artificial tears, or medical therapy. And this medical therapy in the form of oral non-steroidal anti-inflammatory drugs like ibuprofen 800 milligrams 3 times a day. Also, you may consider using topical steroids, but again with caution, and you have to make and establish the diagnosis of episcleritis because in case of scleritis, topical steroid may be contraindicated. So the main treatment of episcleritis is just observation and supportive measure in the form of cold compresses and iced artificial tears. Again, if there is considerable pain or discomfort, so you may consider oral non-steroidal anti-inflammatory drugs or topical steroid with caution. Again, if there is recurrent episodes of episcleritis, you have to treat the underlying associated systemic disease. So let's discuss a more important thing regarding inflammation of sclera, which is scleritis. It's less common than episcleritis, but it's much more important than episcleritis. Again, why? Because scleritis is likely to be associated with underlying systemic disease. So scleritis is the inflammation of the sclera and can be can be presented as painful red eye with or without visual loss. Again, scleritis can be classified into two main categories according to the anatomical classification, which is based on recti muscle insertion. We divide it into anterior scleritis, where the inflammation of the sclera is confined to the and anteriorly to the insertion of extraocular muscles, and posterior scleritis, where the inflammation is posterior to the insertion of the recti muscle. So clinical types: anterior scleritis, inflammation of the sclera anterior to the insertion of the recti muscle. It's much more common than the posterior scleritis, and it has two types. What's called the non-necrotizing and the necrotizing form. From its name, non-necrotizing, so there is no tissue necrosis, so it's a milder form. It is a mild form, and there is less pain and tenderness. And again, it's divided into two types, either diffuse non-necrotizing scleritis and nodular non-necrotizing scleritis. The other form, which is necrotizing, there is tissue necrosis, and again, it's either associated with inflammation. We call it necrotizing scleritis in presence of inflammation. And another one, which without pain and without inflammation, we call it scleromalacia perforans, where there is tissue necrosis and even perforation of the tissue without pain or inflammatory signs or redness. So how does it look? So this is a non-necrotizing form of scleritis. So there is a nodule here, which is deep in contrast to the episcleritis nodule. Episcleritis nodule is superficial and can be easily mobilized on the surface of the eye. Here, no, you are not able to move this nodule. So you can't move this nodule on the surface of the eye because it's deep inside the scleral tissue. So this is the nodular non-necrotizing scleritis. There is inflammation of the sclera itself, there is tissue congestion, there is nodule, and this nodule can't be mobilized on the surface of the eye. And there is another form of non-necrotizing scleritis, which is the diffuse form. There is diffuse inflammation of whole sclera, and again, it can be sectoral or can affect the whole sclera. We call it diffuse form. Again, all the scleral tissue is inflamed, and the eye is congested. Here, there is no signs of tissue necrosis. On the other hand, this is a necrotizing form. You can't see the tissue necrosis here and here. There is loss of tissue, necrosis of the tissue. Here, what is called scleromalacia perforans, where there is perforated sclera without much inflammation around the eye. There is no inflammation in the scleral tissue. But here, there is tissue necrosis and there is inflammation all around. So this is the necrotizing scleritis with inflammation. So what about the posterior scleritis? Posterior scleritis is the inflammation of the sclera posterior to the recti muscle. So the signs may be not that evident when you examine the anterior surface of the eye. The signs is mainly posterior in the retina. So inflammation of the posterior to the insertion of recti muscle, which affects the sclera, and this can lead to serous retinal detachment and what's called choroidal folds. Here there is retinal edema, even optic neuritis, and here also choroidal detachment or retinal detachment. And of course, there is pain open eye movement because of the attachment of the muscles, the extraocular muscle to the sclera, and also the inflammation of around the optic nerve. All of these can lead to pain open eye movement. Causes of scleritis, mainly systemic underlying disease. So this is the most important significant difference between episcleritis and scleritis. And you should be able to differentiate between both conditions because it's a total different story. So scleritis is a significant dangerous disease because it's not dangerous in itself only, but also because of signifies the presence of underlying systemic disease. And the most important association is rheumatoid arthritis. It's the most common cause or underlying systemic disease. And some patients may present just with scleritis before the appearance of the symptoms of rheumatoid arthritis. So again, in scleritis, you have to search for underlying cause, and the most common underlying cause is rheumatoid arthritis. Other systemic association, like other connective or collagen vascular disorders, like systemic lupus and seronegative spondyloarthritis, in addition to infection or like TB, syphilis, herpes zoster, or gout, or if there is past trauma, either physical or chemical trauma. It's less likely to be idiopathic. So when you encounter a case of scleritis, you have to search for underlying systemic disorder. And again, it can, the associated systemic disorder usually present in at least 50% of the cases. Clinical picture, general examination, you have to exclude any underlying systemic disease. So look for signs and symptoms of rheumatoid arthritis, like deformity of the hand, systemic lupus, malar rash, and ocular manifestation in the form of the symptoms and signs. You have to know that the most important symptom of scleritis is the ocular pain. And the most important sign is the redness, which has a characteristic findings. So the symptoms is the ocular pain, which is gradual onset with globe tenderness, and there may be pain in ocular movement. And pain is an important indicator of the activity of the disease. Another thing is the red eye, which can be localized or diffuse, and the decreased vision may be present, especially in posterior scleritis. Signs, red eye with characteristic violet hue or violet bluish hue. Why? Because here the vessels which is affected is lying deep in the sclera. That's why it doesn't have a pink bright color. However, it has what's called violet bluish hue because the congestion of these vessels in the sclera. You can see here there is some sort of bluish or violet bluish hue of these affected vessels. Okay. Another thing, there is scleral edema and overlying ecchymosis of the conjunctiva. There is no blanching with phenylephrine. This is 10%. So when we differentiated between episcleritis and conjunctivitis, we used the phenylephrine 2.5%. Here, to differentiate between episcleritis and scleritis, we use much more strong concentration, which is phenylephrine 10%. Phenylephrine 10% will blanch the episcleral vessel, but won't affect the deeper scleral vessels. Okay, so this is an important pharmacologic differentiation between both conditions. Again, other signs depend on the location of scleritis. In anterior scleritis, there may be associated inflammation of the anterior eye structure, like cornea, corneal keratitis, or corneal thinning, or uveitis, and elevated intraocular pressure due to inflammation of the trabecular meshwork, trabeculitis. In posterior scleritis, again, there may be retinal detachment. Here are some of these signs. Again, there is scleritis here with thinning of the cornea and thinning of the sclera here. Here there is conjunctival ecchymosis. Here is keratic precipitate as indicator of uveitis. Again, here there is inflammation and thinning of the sclera. Here there is serous retinal detachment. Is there any investigation we can do? Yes. In management, you have to investigate the order some investigations like ocular B-scan ultrasonography, which will reveal thickening of the sclera due to scleral edema, and this is obvious in posterior scleritis. So there is thickening of the scleral tissue posteriorly, and what's called the T sign. Here, this is the shadow of the optic nerve, and around the optic nerve on both sides, there is thickening of the scleral tissue, and there is some fluid also beneath the retina. Here, this is the shadow of the retina. Here, this is the shadow of the optic nerve, and here, this black area where there is an arrow indicating the presence of fluid here. So this is what's called the T sign. Also, you may order MRI scan, and again, it will highlight the area of scleritis and the inflammation as white area on MRI scan. Also, it's so imperative to look for underlying systemic disease. Treatment. Again, treatment. Scleritis is a vision-threatening condition that requires urgent referral to ophthalmologist. So it's beyond the ability of general ophthalmologist or general practitioner to deal with, but there is a responsibility to spot this patient and these cases and refer them. Again, why? Because it's vision threatening or sight threatening, and again, it can be life threatening because of the presence of underlying systemic condition. The treatment is mainly systemic treatment for underlying systemic condition if present, and also systemic treatment for underlying scleritis. So what is the treatment of the scleritis itself? Medical, it's mainly systemic. Oral non-steroidal anti-inflammatory drugs, oral steroid or IV steroid, but less commonly topical, because topical steroids should be used with caution, especially in necrotizing scleritis, because it can lead to acceleration of the tissue necrosis. Also, immunomodulatory drugs like methotrexate, cyclophosphamide, and whatsoever. And this may be required to control the systemic as well as the ocular disease. So again, treatment of scleritis is systemic for the control of the ocular manifestation and systemic condition if present. Again, medical treatment in the form of oral non-steroidal anti-inflammatory drugs, systemic steroid, oral or intravenous, and immunomodulatory drugs. Surgical intervention is less likely to be required, and it's only required if there is scleral perforation or pending scleral perforation where there is much scleral thinning. What is the prognosis? So the prognosis usually depends on the severity of scleritis. More severe cases like necrotizing scleritis have high incidence. A patient with this condition have high incidence of visual loss and increased mortality rate as well because of the underlying systemic condition. However, milder cases and also cases which is associated with rheumatoid arthritis has better prognosis when compared with the severe cases which are likely associated with more severe connective tissue disorder like polyarthritis nodosa, for example. Again, patients with mild to moderate scleritis usually maintain excellent vision, and scleritis may be active for several months or years before going into remission. Here is an important comparison between the both conditions, episcleritis and scleritis. Episcleritis is much more common than scleritis. However, scleritis is much dangerous and is likely to be associated with connective tissue disorder and most likely rheumatoid arthritis. However, the most common cause of episcleritis is idiopathic, without underlying systemic disease. It's rarely associated with underlying systemic disease, and it only happens usually with recurrent cases. Signs and symptoms, here it's mainly discomfort in episcleritis. So the pain is mild or there is no pain. However, scleritis, usually there is severe pain. Pain is the most significant and most important symptom of scleritis. There is no visual loss in episcleritis. Visual loss is likely in scleritis. Here's the inflammation. There is bright red eye, pink bright red eye, again, because the involvement of the vessel in the outer layer of the sclera. That's why you are able to see the vessels as bright red. However, there is violaceous red eye in case of scleritis because there is congestion of the deep scleral vessels. Episcleritis, usually the onset is acute and subacute. However, scleritis is usually gradual onset because of the association with systemic disease. What is the effect of phenylephrine? 10%, it will affect the vessels on the episcleral vessels with vascular blanching. However, it has no effect on the deep scleral vessels. Severity, scleritis is mild, scleritis is severe, prognosis is good in case of episcleritis, poor in scleritis, of course. Again, the treatment in episcleritis is mainly supportive, even no treatment is required in most of cases, and sometimes oral non-steroidal can be used in case of pain or discomfort. However, treatment of scleritis is mandatory to control the systemic manifestation and also the ocular manifestation. And again, the treatment is mainly systemic, non-steroidal, oral non-steroidal anti-inflammatory drugs, systemic steroids, either oral or intravenous, and immunomodulator like methotrexate and cyclosporin and methotrexate. So in conclusion, scleritis is often associated with underlying potentially lethal systemic disease. This is the most important message of this lecture. And this is not the case of episcleritis. Again, patients with severe disease of scleritis have significant ocular and systemic morbidity and short lifespan because of the underlying systemic condition. Scleritis is a really dangerous condition. Pain is the most prominent feature of scleritis, and red eye is the most common sign. Systemic treatment is the mainstay treatment of scleritis and not topical treatment. Here is my contact. If you have any question or anything you wanted to ask about, you can contact me on these emails or WhatsApp, and you will find me at the outpatient clinic in ophthalmology department. Thank you.